So basically the idea of this video is to go through a subjective examination in each section and go through the questions we'd ask and why we would ask them. At the end of the subjective examination, you should know or have a very good, clear understanding of what's going on, or that you need to be referring that on to someone else. So the first part of the examination we're going to talk about is the history of presenting condition. One of the key things we want to talk about in this area is the mechanism of injury. So we want to know how the pain started. Was there a specific injury? If there was it traumatic? And then with the trauma, you want to know sort of exactly what happened. So the force, the positions that someone was in as they fell. This is going to give you an understanding of what structures may be damaged in that individual. Also with mechanism of injury, if they haven't had one, then that might be leading you down into a different way of thinking in terms of ruling out red flags. Obviously with a trauma, you could be thinking fracture and you want to rule out fracture in terms of your red flag conditions. So the second big thing is length of symptoms. So we want to know how long someone has had their symptoms. Is it something that's been a new thing? Is it something that's been chronic? Again, this will give you an idea of thinking about injury healing timeframes and whether there's any central sensitization going on that person, or whether it is truly a more of a mechanical type pain. Also, you can talk about any changes around the time of the injury in terms of hobbies, sports, etc. So even if there's not a specific mechanism of injury, you can still talk about certain things around the time when it started that could have been a predisposing factor to the pain beginning. Then what you want to go into is previous injuries in this area and previous treatments. So have they had any previous injuries of the same sort in the past? Have they had a pain of the same description in the past? And if so, have they sought any treatment, and have they sought any treatment for the condition they're coming in to see you with up to this point? So this is going to give you an understanding of what treatments they've had and whether these have worked or whether these haven't worked. And the key thing with this one is to really go into what those people have done with them. So, just because you've had physiotherapy doesn't mean it's been good physiotherapy. It doesn't mean you've been given good strengthening or loading protocols, or that you've been talked to about all the things that we'll go on to mention later in the video. So you want to make sure that the treatment they've had is appropriate. And we also want to think about previous investigations or consultations. So has this person seen a consultant, a GP? Have they had any investigations, x-rays, scans? That'll give you a good understanding of again, what they've had up until this point, and also whether if they've had scans, it's really useful because you can rule out certain conditions, especially the red flag type conditions, and it means you can hone your clinical reasoning and hypothesis down another route. So that's our main things we want to look at with our history of the condition. And then we want to go on to talk really more about the presenting condition as it presents now. First big thing we want to talk about is the location of pain. Again, this is where you can use your body chart to write down or to draw in the body chart where the pain is. So we want to know where the pain is, where it started, and how it's developed to this point now. So has it spread? Is there any referred pattern of pain? So is it localized or is it more referred pain? And then we want to go into the nature of that pain. So what the quality and intensity of the pain. So how high on a VAS scale or an NRS scale of 1 to 10 or 0 to 10, 0 being no pain, 10 being excruciating, where would you put the pain? And also, how does it feel? Is it a burning, aching, stabbing? Obviously you want to keep these open-ended questions as possible, so get the patient to describe how they would describe their symptoms. Also, with regards to this, you want to think about the neuro symptoms. So are they getting pins and needles, numbness in the distribution of the pain where they're feeling the pain, or in any other areas that would make sense in terms of a referred pattern from this localized source of pain. Another big thing with the presenting condition is ags and eases, so aggravating factors and easing factors. So what makes the pain worse and what makes the pain better? And this is going to give you an understanding of positions or activities that make that pain worse, and then you can work out from that what structures are likely or not likely to be stressed or put under load during these particular activities. Another key question in the presenting condition is a diurnal pattern. So just a 24-hour pattern. Is the pain, does it have a pattern during the day? Is it worse in the morning? Typically with our arthritis type patients, you might get worsening in the morning or stiffness in the morning, and then getting better or easing during movement during the day, and then getting worse again at night time. So that's your kind of classic arthritis pattern, and there are lots of other patterns out there. But again, you want to just find out, is there a pattern, and what that pattern is over a 24-hour period. And the other key thing that fits in with the diurnal pattern is night pain. So have they got pain at night? And not just have they got pain at night, but also, how does that affect them? So lots of people will complain of pain at night, but when you question them more thoroughly, you'll realise that it's just because it's when they turn, or it's when they move the body part involved, that they get their problems, because it's pain that wakes them up. So you want to make sure that it's not unremitting pain at night. So unremitting pain at night would be typically someone that can't sleep at all, that has to get up and walk the halls, that is really, really struggling with their sleeping rather. And this is going to again be one of your red flag type conditions, or potentially a red flag type condition if it fits in with other patterns during the subjective examination. So the next section I'm going to talk about is the special questioning. So again, like I said before in this video, this doesn't have to come in this specific order, but I'm just going to go through it in the order that I'm going to go through today, and you can mix and match these all the time. The special questions, kind of in my head, I fit them into different body parts. So things like the neck, so any neck, head, thoracic type pain, you want to rule out your 5 Ds and 3 Ns. So the 5 Ds is your dizziness, diplopia, dysphagia, dysarthria, and drop attacks. So speech, swallowing, eyesight, dizziness, and feeling faint. Then you've also got your 3 Ns, so your numbness, your nystagmus, so those black spots in the eyes, and nausea. So all of these things, especially in combination, would be something that you'd be wanting to look out for with cervical spine conditions that may indicate some sinister or pathology that you would want to refer on to get cleared before you treated them for a musculoskeletal problem. Then you've also got your more general spinal red flags or special questions, especially for the lumbar spine. So obviously we've got our cauda equina types questions that we would ask. So bladder or bowel dysfunction, your saddle anesthesia, gait issues, and sexual dysfunction. You can go into these in more detail if they say yes. So again, with the especially with the bladder and bowel, with bladder it would be things like urgency, things like not being able to feel when you're empty, not being able to feel when you're full, leaking obviously, just having that sensation of going to the toilet and then needing to go again because you haven't fully emptied yourself. So all these sorts of things. Saddle anesthesia, I often just ask, do you get any numbness in the area where you wipe your bottom or in your private parts? And they're usually pretty clear with that. Obviously sexual dysfunction, again, it's one of those questions that's awkward to ask, but you just have to ask, and I think if you frame these questions, so I always will frame this in the sense of I'm just asking these questions because we want to rule out anything really sinister going on. They might sound a bit weird, but they're due to the fact that you've got some leg pain or back pain, and we want to make sure we're not missing any serious conditions, and patients are always fine when you frame it like that. Then you've got more of your special questions in terms of systemic problems, so in terms of ruling out things like cancers and infections and things of that nature. So these questions would be your unexplained weight loss, any unexplained weight loss, night sweats or fever at night, unrelenting pain, and generally feeling unwell in yourself. So those would be the ones that we would really want to look out for cancers, infection, and just general systemic type conditions. Then you want to go through more of your peripheral special questions. So this would be things, again, for the knee and for joint related problems, where you might want to ask about clicking, about locking, about giving way, any bruising, swelling, redness around the joints. Again, all of these things are going to give you more information about the joint themselves. Obviously, with things like swelling and redness, you might be thinking about inflammation. So if there's swelling and redness and heat, and you're thinking an inflammatory process going on. Things like lumps and bumps, as if there's been trauma, then you'd be thinking potential fracture. There's lots of other things that you would want to think about with regards to kind of peripheral questions. Obviously, locking in the knee could be meniscal problems, but generally in terms of, could be intra-articular type stuff going on, or loose bodies. So there's lots of different reasons you'd ask these questions, but just making sure you know why you're asking those questions for those specific joints. Again, clicking is not something we ever really worry about too much, but if that's associated with significant symptoms, then it may be that you've got some rubbing of tendon over bone, or just random noises in the joints as well. So again, that's where the objective examination will come into play. The other thing when you're talking about redness and joint pains as well is thinking about inflammatory conditions and rheumatoid arthritis, which we'll talk about when we go through our past medical history. But you want to be thinking about patients who have morning stiffness that lasts a long time, so morning stiffness that lasts a couple of hours, as opposed to sort of 15 to 30 minutes with your typical osteoarthritic patients. If they have swelling of the small joints in the hands and feet, if they've got things like inflammatory bowel conditions, Crohn's, uveitis, so inflammation in the eyes, all those sorts of things, then you might be thinking along the lines of a more rheumatology type condition, especially in those thoracic spine patients who are getting kind of flare-ups and who are better with movement and worse with rest. So if you've got those type of symptoms, then you'd be thinking again along your rheumatoid arthritis type conditions. So if we move on to a past medical history now, so a classic thing that I put in my notes is thread stock, so your thyroid, your heart, your rheumatology, epilepsy, asthma, diabetes, osteoporosis and cancer. So typically with thyroid dysfunction, you're looking at, they may cause musculoskeletal symptoms like frozen shoulder, Dupuytren's contracture, trigger finger, limited joint mobility and carpal tunnel syndrome, a classic with these type of conditions. So again, if you've got that condition in someone with thyroid problems, then again, you can be putting that into your thinking of clinical reasoning. Then you've got heart, so chest pain, shortness of breath, dizziness, fainting, nausea, fever, those sorts of things. Problems with pain in the arm, those are the sorts of things that you want to be looking out for. If someone's had previous heart problems, then you want to make sure that you're thinking about those symptoms in their presentation, because it may be that the problem's actually coming from a heart condition rather than a musculoskeletal cause. Then we want to think about respiratory diseases, so COPD, and this can predispose people to osteoporosis and muscle weakening disorders due to often the long-term use of steroids, which can weaken soft tissue and bone. So you want to be thinking about that. Epilepsy, obviously you can get things like peptic ulcers, and apparently arthritis is 8 times more likely with epilepsy, and it's also linked with autoimmune disease, which is one of the reasons why we'd ask this question about epilepsy. Diabetes we know can have a whole host of factors, which is not great. So CRPS is more likely, neuropathic joints can be more likely, carpal tunnel, frozen shoulder, tendon problems, all the osteoporosis, all these sorts of conditions are more likely if you've got diabetes. And I think that's what people with diabetes don't really realise, is how much it has an impact on their general health as well. So obviously we've mentioned steroid medications before as well, but we'll mention it again now. But steroid medications can be a factor for things like avascular necrosis, osteoporosis, tendon rupture, tendinopathies, those sorts of things. So again, asking about steroid medication, which I didn't mention with the thread sock. So the S is for steroids, long-term steroid use. So that would be something we would definitely want to look at. Osteoporosis, obviously if someone's had a trauma and they're osteoporotic, even if it's not a large trauma, it could be that you've got a fracture. Also you can get things like pathological fractures, so fractures, wedge fractures in the spine, etc. with osteoporosis. So if someone's osteoporotic, then you want to be obviously mindful of your red flags when you're talking to that patient. Then we want to also think about other things with past medical history, like allergies, so whether the person's allergic to medications, to taping, etc. You don't want to be giving them or advising on treatment that is going to harm them. And then also surgery, so previous surgery in the area of problem, or surgery, general major surgery. So we want to, again, sometimes people will not be forthcoming with their general health, and then you'll ask them about surgery, and then they'll say they've had a AAA bypass surgery and this and that, and then you realise that actually their general health, although it might be okay now, has not been great in the past. So sometimes that can give you a really good indication of where they are from that point of view. The other thing I want to do general health wise is talk obviously about medications. So what medications someone's on. Again, it's really good to go through this with people, because often they will say they're fine, and then you realise they're on statins, they're on cholesterol medication, they're on other medications which actually show that they're not in as good health. They might be on medication like metformin for diabetes or things of that nature. So we want to make sure that we're asking about medications as well, because again, if people are on those things, that's important. The other thing is things like citalopram and other antidepressant medications. are things that people often won't mention in their general health, but then when you talk to them about that, you realise there may be some mental health things going on there as well, which obviously is going to be important for going forwards, and you may need to delve into that more deeply, depending on obviously the presentation and the condition that you're dealing with. So then we're going to move on to our social history. It's important to realise if they're working currently or not. If they've got an upper limb problem, you might want to ask about whether which hand dominant they are as well, so that you have an understanding of that, and whether they play hobbies, sports, what their physical activity is like outside of their work. So I think that's a really key thing as well, to just find out what they generally do day to day and how active they are, which will give you an understanding of whether it's an underuse type disorder, overuse type disorder. The other thing you can talk about here is things like smoking and drinking, which we know have an impact in terms of people's general health, in terms of soft tissue, joints, etc. And a final few points I wanted to talk about. I think throughout this subjective examination, you want to be thinking and talking to the patient about their expectations and their goals. So, why are they here to see you as a therapist? What are they looking to get out of it, and what are they expecting? Some patients have really kind of poor thought processes around what physio can offer and what we can offer. They think you're going to have a magic wand that can fix them, even though they have had osteoarthritic pain for 20 years. So, it's good to get an understanding of where that person is, and whether you need to do some discussion or have some discussion around the realism of their goals and their expectations, and whether that's something that you can offer. The other thing that the subjective will really give you is a good SIN factor. So this is a good thing to have in mind as you go into the objective assessment. SIN factor just meaning severity, irritability and nature. So if you've got someone, for example, with neck pain raging down the arm with pins and needles and tingling into their little finger and their ring finger, then you might be thinking that there's some sort of ulnar nerve neuropathy. So ulnar nerve is affected, whether that's coming from the actual nerve itself or whether that's coming from the neck. Obviously that will be something you'll go into with your objective. And so the nature would be more of a neuropathic pain that person's getting. Your irritability would be how quickly that can be irritated. So it might be that actually just turning my head to the right irritates that nerve and gives me pins and needles and tingling, but that when I turn back, that goes immediately. So that would be fairly low irritability. If I was to turn my head to the right and it irritated it and then it was there for half an hour, that would obviously be high irritability. So in your objective, you want to be thinking about either not doing those movements till the very last, or potentially, if you can do work around it, maybe not doing those movements at all, because it's going to massively affect the rest of your assessment. And so it just gives you an idea of how you would plan your objective assessment. And the severity as well would be then how severe it is. So when I turn my head to the right in this example, out of 10, is that pain a 2, in which case actually maybe I can push it into that range, or is it a 10, in which case I might want to be a little bit more careful in terms of the tests I do. So it's just a good way to work out with someone how you're going to plan your objective assessment in a way that you can glean as much information as possible from that person and enable you to make the best decision possible about management of that condition moving forwards. And the other thing that goes without saying, which kind of we talked about a little bit with patient expectations, is yellow flags and biosocial factors, or biopsychosocial factors. So we know that musculoskeletal pain is not just the biological; it's massively to do with the social and psychological as well. So, what are that person's feelings around their pain? Do they feel they can get better? Do they have a really poor experience with physio potentially? And just getting an understanding of really how that person feels about their pain, and the factors that may feed into that. Sometimes obviously it was worthwhile asking, was there anything different in terms of stress, lifestyle, what you were eating, sleep? That's usually the 4 things I'll say to someone if they haven't really given me any information on that. So around the time of your pain, any differences in your sleep, any differences in your lifestyle, any differences in stress, or anything that was different about your life at that point. Often it's no, but sometimes you might glean something there that you may have otherwise missed. And I think the other thing that the last thing I want to sort of mention is that subjective examinations are not always going to be perfect. You're going to have people who come in and they kind of completely stump you, and I have loads of times where I just think I'm not quite sure what's going on here. You just have to get as much information as you can in the time that you've got and do the best job you can in trying to hypothesize and clinically reason why you think what you think in terms of what's going on, and then also what you're then going to do about it. So I'm going to do lots more videos on the channel to do with physiotherapy in the physiotherapy section of the channel, and I want to talk a lot about clinical reasoning and different conditions and how we would think about different things. Any videos that you guys might have and you know, ideas of what you might want, then yeah, please give me a shout. And this is meant to be collaborative. You know, I'm by no means the perfect physio. I've got lots to learn, and there's lots of people out there that are a lot better than me and have amazing, you know, more amazing knowledge. But what I want to do with these videos is try to, you know, give some, you know, impart some knowledge in terms of what I know, what the things that I've kind of learned over the years that I think have been useful and that I've taken from other people that I've worked with and mentors, etc. And then also, you know, get in the comments below and let me know if there's anything that you think I've missed, if there's anything that you think's really important to talk about in a subjective. You know, if we can hopefully help the whole physio and therapy community out there to make to have better subjectives and therefore help people more, then I think that would be an awesome thing. So finally, obviously, if you've enjoyed the video, guys, I want you to leave a like. It massively helps the channel out, and if you can subscribe and click the bell icon, that means you're going to get more notifications of videos when I release them. Hopefully you've enjoyed the content that I've shared today. I've enjoyed sharing it. It was something I, you know, wrote down loads of stuff on the Mac and kind of just went through each individual section. So hopefully it's kind of been as kind of concise. I know it's probably a long one video wise, but probably as concise as I think I can make it. If you've got any ideas or comments on other videos of the channel going forwards, then please give me a shout, and I will look forward to seeing you next time.